Hi, everyone. I just want to welcome you all to our first prostate cancer online health talk. Tonight, our talk is going to be focused on active research and clinical trials here at the clinic focused on prostate cancer. My name is Dr. Betty Wang. I'm a urologic oncology fellow here at the clinic. I did all of my medical training previously in Canada before starting my fellowship here in July. Tonight, we're joined by Dr. Robert Abouassali and Dr. Ziad Chouin. Dr. Abouassali is just running late in the OR today, so he may be joining in later on. He's an associate professor and urologic oncologist here at the Cleveland Clinic. He's been appointed since 2017. His clinical practice spans all of urologic oncology, including prostate, kidney, and bladder cancer. He has a focus in minimally invasive and robotic surgery. And then with us as well is Dr. Chouin. He joined the clinic in 2021 as a full-time oncologist. He sees patients again with all kinds of urologic cancers and performs a high volume of robotic cancer surgery. Dr. Chouin has a particular research interest in prostate cancer active surveillance, artificial intelligence in urologic oncology, as well as prostate cancer focal therapy. So without further delay, we'll get started on the slides with Dr. Chouin.
Thanks, Betty, for that introduction. Alrighty. So yeah, Dr. Abouassali, he's currently stuck in the operating room, which is not something that happens infrequently here. So I'm just going to go ahead and present his slides talking about recent advances in prostate cancer. What's great about prostate cancer is that, every day it seems there's a major breakthrough in whether it's the diagnosis and testing to find out if you have prostate cancer, or understanding kind of the mechanism and underpinnings of the disease, as well as new treatment options, both for people who have localized disease that's curable, as well as people who have metastatic disease and the cancer has spread outside of the prostate. For the gambit is very wide and spans a lot of different areas, and for the purposes of time, we're going to be really focused today on the early diagnosis as well as treatment for localized prostate cancer. So we'll be talking mostly about people who have cancer that has not spread outside. What we're going to be talking about is precision. Some of the recent advances has come down to precision testing, using genomic testing as well, finding kind of the genetic makeup of the disease and understanding how a lot of the mutations can occur both in the DNA of the patient, but also in the DNA of the cancer. And so a lot of people can get personalized genetic testing, both of people who do not have cancer to find out if they're higher risk, such as BRCA1 and BRCA2. But also when you have a diagnosis, they can test the RNA of the cancer that shows if they have any high-risk mutations that have developed. So if you want to go to the next slide, great. Yep, so there's a lot of promise in this area, and this is something that we've really done a lot of research here at the Cleveland Clinic, but elsewhere as well, understanding how there's other forms of less invasive testing, liquid biopsies looking for circulating tumor DNA, also looking at how these mutations and the genetic landscape of the cancer can help for identifying treatments that may be more effective for that particular type of cancer. And so this allows us to adapt our treatments in a more personalized way to have better outcomes. Right, next slide. The major advances that we face in people with localized disease has also been in improving diagnosis with imaging. The major one that we may talk a little bit about in the second part of this presentation is about the PSMA PET. So the PSMA is a prostate-specific membrane antigen, and it's a protein that's expressed on the cells that are concerning for prostate cancer, and that can light up when we attach a ligand to it, which is important for testing and diagnosing prostate cancer. This is kind of the area. This is a CAT scan. So it's a CAT scan that is very specific for prostate cancer. So a lot of times we would be relying on very old types of imaging like a bone scan, which still is used today, but not as frequently. as well as just a conventional CT scan. And the PET scan has really improved our diagnosis of metastatic prostate cancer, as well as helping us identify if there is cancer localized to the prostate and where it might be localized to. So this is something that has been a really big revolution in diagnosing prostate cancer and determining if you're a candidate for localized disease. If you have cancer that has spread outside of the prostate, which may be better diagnosed with a PET scan, you may not be a good candidate for localized treatment. Other major advances have been the improved treatments for prostate cancer that may have already spread outside of the prostate. So these androgen receptors, the prostate cancer, similar to breast cancer, is very mediated by androgens like testosterone, and in the case of breast cancer, estrogen. And what we know is that blocking these receptor pathways have been really effective for treating and helping put the cancer in remission. A lot of times these treatments have been combined with other therapies, whether it's chemotherapies or other types of localized treatments like radiation, and have started to make their way into the earlier stages of prostate cancer. There was a recent study showing that some of these medications, like one of them, enzalutamide, has been helpful in people who have a recurrence of their cancer after surgery and may be a candidate for radiation therapy, but also combined with these androgen receptor medications that block the pathway have shown improved outcomes. Another thing that has been a very major advance, which I'm sure a lot of people already know a little bit about, but robotic surgery has really minimized the surgical treatment of prostate cancer, the morbidity, and improve the recovery of prostate cancer surgery. We do a lot of, the vast majority of our surgeries are done robotically, but we found a way to even further minimize the morbidity associated with treatment for prostate cancer. So a lot of times people, even with the robotic surgery, they would have to stay in the hospital 1 to 2 nights. We found ways to make this an outpatient procedure and also avoid the prescribing of opioids, because that has been such a, improvement in reducing people's reliance on opioids, and it's a major problem in the United States. But we found ways to make it just requiring Tylenol and ibuprofen. A lot of that has related to our improvements in our robotic techniques, newer development of robotic instruments. The single port robotic system is one of them that has been pioneered here at the Cleveland Clinic. Also, newer surgical approaches that have improved the recovery of the urine control after surgery by sparing some of the important support structures. That's the Retzius sparing approaches. And that's something that has really improved the recovery of patients and reduced the morbidity of treatment. Also finding ways to have unique accesses, the transvesical approach, where we do the surgery through the bladder, which has really improved the recovery after surgery. And also for people who have a lot of scar tissue, this is another way to avoid going through the scar tissue from prior surgeries. The other major innovations have been also in the treatment of localized disease with radiation. So SBRT, or stereotactic body radiation therapy, is a way of improving the delivery of radiation for treating prostate cancer. It actually has found a way to reduce the number of treatments required. Previously, it's been many dozen treatments to the prostate for localized disease, but they found a way to reduce the number of treatments, which has helped patients go about their life and reduce the trouble from having to have their prostate cancer treated by increasing the dose. A major shift in treating the prostate cancer that's localized has been the reliance on focal therapies. Focal therapy is a new promise of ways of avoiding treating the entire prostate. A lot of times prostate cancer is multifocal, meaning it's in a number of different locations, and that's why traditionally we've found ways to We've found that the best way to treat prostate cancer and cure cancer is by treating the entire prostate, either with removing the entire prostate or by treating the entire prostate with radiation, whether it's the external beam radiation or the radioactive seeds. But for select men who have cancer localized to one area, we can do focal therapies, whether it's with an high intensity focused ultrasound or focal nanoknife, which is delivering an electric current through the prostate to kill the prostate cancer. There's also focal cryotherapy, where you're freezing part of the prostate, focal brachytherapy, where you're delivering radiation through seeds to another part of the prostate where the cancer is located, or partial surgery, where we remove only part of the prostate surgically. These are all kind of in the very early stages of their investigation, but we are offering them to select people. It's something that this has been a major breakthrough in reducing the urinary and sexual side effects from prostate cancer treatment. Not everyone's a candidate, though, so that's something that's really important to keep in mind. Now, we also have more evidence to support that not every cancer needs to be treated. Previously, we used to treat almost any prostate cancer, even if it was low risk, because we were worried that this could be developing into a life-threatening cancer. Well, we've done a lot of studies and research, and a lot of that has shown that surveillance for some men, especially with low risk prostate cancer, is safe, and it's the best way to reduce the side effects that can occur with prostate cancer treatment. So we found better ways to select people, and that's with imaging like MRI or PET scans, as well as looking at other genomic tests. And thankfully, with greater education and better selection techniques, we've improved the uptake of active surveillance. We're also offering surveillance for some men who have intermediate risk prostate cancer. That's because not every cancer that's intermediate risk, some of them behave more like low risk prostate cancer. So finding ways to improve our active surveillance so that we know it's safe and we're not missing the window that we could treat and cure the prostate cancer. And just kind of what we know it's better for patients, which is we don't need to treat every prostate. All right, and then what we can now shift into talking a little bit more about the specific research that we're doing here at the Cleveland Clinic, talking a little bit about the clinical trials that we're offering. It's something that there's numerous projects that we work on here at the Cleveland Clinic, a lot of options and opportunities for patients. A lot of the research that we're going to be presenting today, some of it has not even been presented nationally, and that's great to kind of share with you some of our new groundbreaking research and some of the clinical trials that we're talking about. So a little bit about what we were talking about before is finding ways to kind of better understand the behaviors of these prostate cancers, and that's by looking at the genomic signature from the cancer. And so a lot of times we use these genomic tests where they take the tumor that has been biopsied, or after surgery, they can select and sample the cancer, send it for testing to see what sort of mutations have occurred. And it's very important to understand the biology of these cancers and the behaviors, because, well, if it looks under the microscope a certain way, some of these cancers actually are bad actors and may behave more aggressively based on what we know about their DNA mutations. So we actually just had a recent publication showing that some of our cancers that have what we call cribiform and intraductal patterns, which are very high risk patterns associated with lethal prostate cancer, that we know that some of these have a higher genomic risk and a genomic signature. So what we can do is we can take a test called the Decipher test, which a lot of people may have heard about. And that's something that is commercially available, and it's something that you can, ask your provider if you had a biopsy, if it's worth taking a Decipher test, because what we know is that if you have a higher score, you may be at a higher risk of harboring cribiform or intraductal prostate cancer, which is something that you don't want to be, less aggressive with. It's something that you probably do not want to do surveillance for. And so this is a better way of determining, well, is this the kind of cancer that we watch, or is this the kind of cancer that we need to treat? And if we do treat it, is this a cancer that might have a higher risk of risk? We also use that same genomic signature to determine that there are certain types of cancers that may arise from different parts of the prostate. And we've known that some types of cancers that arise from different zones may behave or may look more aggressive, but actually may behave less aggressive. So we actually did a recent study looking at uh, about 100 men who've had prostate cancer diagnosed from the transition zone, which is near the top of the prostate, and compared it to the genomic signature of the peripheral zone. And we got a lot of really great data from this, and we found that certain cancers arising from the transition zone have a lower genomic risk. So these cancers may behave less aggressively, although on MRI they may look more aggressively. We've found that there's been a few mutations that have been different in the transition zone compared to the peripheral zone. The peripheral zone's near the back of the prostate, where most prostate cancers are arising from. But this is the first study that has shown that those transition zone tumors near the anterior or top of the prostate may behave less aggressively. So this is something that we're going to be doing larger studies comparing maybe multi-institutional results to confirm these findings, but it's a very exciting way to maybe we can treat these differently, or maybe watch certain transition zone tumors uh, with active surveillance instead of treating them. Another major advance that the Cleveland Clinic has participated in is transitioning our biopsies to the transperineal biopsy. The traditional biopsy is the transrectal prostate biopsy, where the ultrasound probe and the needle go into the rectum and then sample the prostate through the rectal wall. Traditionally, this has been associated with a high risk of infection. So a lot of times people will get severe infections in about 5% of men in some studies that may require being in the hospital, even when we give you antibiotics. So we've transitioned away from the transrectal prostate biopsy, and we found that the transperineal biopsy, where the needle goes through the skin instead of through the rectal wall, has shown a lower risk of an infection. Also, we have a lot of evidence to support that there's a higher risk of detecting cancers that might be hiding in the top of the prostate, which may be a little bit difficult of an angle for the transrectal needle to reach. And the other advantage is that we've been able to avoid giving people antibiotics, which helps breed drug-resistant bacteria. So this is something that in the last year we performed over 1,000 of these transperineal biopsies, and we've done additional research in this area. This is one of the studies that we published on the transperineal prostate biopsy. And this was studies, run by Dr. Klein, Dr. Werneberg, and Dr. Haywood, which showed that there were less bacteria in the tissue with the transperineal approach. So that's kind of what we were expecting, that, well, certain approaches through the skin might harbor less bacteria. That's the kind of pathologic bacteria, that's the bad bacteria. And so the transperineal approach had less of this, bacteria that exists in the bowels, which can lead to severe infections and sepsis. So this was kind of the first study illuminating that there had, maybe why, or proving that our assumptions were likely correct, that it's less of that bacteria gets into the prostate from this transition through the rectum. So the transperineal biopsy has been shown to reduce that risk. This is another study in the diagnosis world that actually Dr. Abou-Osley has been spearheaded. It's looking at micro-ultrasound. So traditionally, when we do a biopsy, we use a regular ultrasound probe. Some of these can have a lower resolution than we'd prefer. And the micro ultrasound, and this is a technique that Dr. Abu Asli performs, is a way of better seeing the prostate on ultrasound. So traditionally, we use an MRI that's fused with a conventional ultrasound to biopsy the prostate. But Dr. Abu Asli has a randomized trial that he's accruing patients for, where he's comparing the micro ultrasound with the fusion biopsy the traditional way. And I'm told that I just got a message that he might be jumping on here in a moment, so we may go back to this slide so we can talk a little bit more about that. We actually have 3 additional clinical trials that are looking at the PSMA PET imaging test. And we're doing it in different scenarios. And you may want to ask your provider if you're at the Cleveland Clinic or are seeing have a urologist or medical oncologist at the Cleveland Clinic if you're a good candidate for these trials. The one that we're currently accruing patients for is called the MIRROR trial. And this is looking at the PSMA PET for patients who have what we call favorable intermediate risk. So traditionally, the PET scans used for people with high risk or unfavorable intermediate risk prostate cancer, because the likelihood that there's been some spread already is on the higher side. But now we're studying it in the favorable intermediate risk, so more early stage prostate cancer. And we're offering patients a free PET scan, and actually it's in whether they would like to undergo treatment with surgery, radiation, focal therapy, or do surveillance. So it's really not going to influence your treatment, but it's a way of getting a free PET scan and finding out, is your cancer localized to the prostate or not. Another one is called the Solar Stage Trial. It's another PET imaging study that we're going to be accruing patients for very soon. And it's using a newer type of metal, copper, which actually has been shown to have a better resolution, which means that they can see the images a little bit more clearly when we're using the CT scan. So it's another option. This is for men with unfavorable intermediate risk, high risk, or very high risk prostate cancer. So this is a study called the Solar Stage trial. Another one is the Solar Recur trial, and this is going to be using the same copper PSMA PET tracer, and it's going to be in men who have had a recurrence after they've had treatment for prostate cancer to find out, has it come back and where has it come back. So that's called the Solar Recur trial. And this is led by Dr. Andre Periesko, who's our radiologist. An excellent prostate cancer trial that we are going to be opening up very soon. We've already had approval for it. We're just trying to find out a little bit more about the nuances of the diet, is looking at the dietary effects of prostate cancer in men on active surveillance. And so what we're trying to unlock here is the dietary impacts on prostate cancer. And it's actually a very unique trial where we're controlling your diet for 2 weeks, and we give you a full set of meals for 2 weeks prior to a prostate biopsy. We're going to be testing a Mediterranean type diet that looks at some of the metabolic impacts. And it's actually the first of its kind study. A lot of times when we're looking at the impacts of dietary management of prostate cancer, we're kind of looking at the aftermath. We look at people who've had prostate cancer and we kind of ask them, well, what your diet has been like. And it's really not a very reliable study, and it's hard to assume what's causing what. A lot of times it's just what we would call associations. So looking at what diet might be associated with a higher risk of developing prostate cancer. So this is one where we actually control your diet and for free provide you for food for 2 weeks before each of your prostate biopsies, which you usually require 2 if you're going to be on active surveillance. And it's a way that we are going to, unlock some of these dietary impacts on prostate cancer. And this is, work led by Nima Sharifi, Dr. Chris Waite, myself, and Dr. Samuel Haywood. Yep, Dr. Abu Asli's here. If you want to introduce yourself, and if we also can go back to his exact view trial, and if you can talk a little bit more about that.
Sure. I apologize. I'm a little late. I was stuck in surgery, but I'm Robert Aboasley. I'm one of the urologic oncologists here at the Cleveland Clinic. I work mostly on the west side of Fairview Hospital and Avon Hospital, but do spend a little time at main campus as well. And in terms of the clinical trial that we have currently available at Fairview Hospital, it's the ExactView microultrasound randomized trial. So this is a multi-center trial. So there's several centers, both nationally and internationally, that are conducting this trial, and it basically compares micro ultrasound, which is a high resolution ultrasound working at 27 megahertz, which gives us a much clearer picture of the ultrasound, which you can see over here on the right, compared to the traditional ultrasound. And so this trial compares micro ultrasound to MRI to the combination of the two to determine whether micro ultrasound is as good as MRI, better than MRI, or just complements MRI. So there's three arms to the study. You can either have an MRI followed by a fusion biopsy, a micro ultrasound followed by a targeted biopsy using the micro ultrasound, or the combination of those two systems. So they're accruing patients, and hopefully we'll have the answer to that question in the next year or so.
All right, and then talking a little bit about the advances of the robotic surgery, which we alluded to before, is the newer robotic platform called the single port robotic surgery. And this is something where we can do the surgery through a single incision instead of multiple smaller punctures. This allows us to get into these tighter spaces, whether it's within the bladder through the transvesical approach, or above the bladder away from the abdomen, called the extraperitoneal approach. And this has been pioneered by Dr. Kayuk, who did the first clinical case in the world in 2018. But together we've currently done over 1,000 single port robotic surgeries. And this allows us for really having more access for people who may have been previously disqualified for surgery. Also, we've shown that it's improved our ability to deliver same-day surgery discharge, as well as providing, opioid-sparing surgery where we don't need to give you any narcotics. And it has shortened the recovery time, but it's not for everybody. It is for still select people. And that's something that has really helped minimize the minimally invasive surgery. And just kind of what we were talking about, not all prostate cancers need to be treated. And so we've looked to expand our active surveillance program and standardize it so that we're all kind of following the same type of protocol. And we also are following a risk-adapted approach, and that's something that we've currently been studying, looking at maybe we can de-intensify active surveillance, meaning not have to poke you as often or take a look under the hood as often. Really, a lot of times trying to rely on less invasive testing instead of doing a biopsy. Previously, we used to do it every year, which is now we look back at that and think that's crazy. But right now, it's something that has been still early in its implementation, and we've also been used it as a good research pathway to determine how we can study these moving forward and improving our quality metrics. We were recently awarded a grant to develop some AI-based algorithms, which can be helpful for predicting people who are at risk for cancer progression on active surveillance and may require treatment. Urologists rely on a lot of different tests, whether it's the MRI, the PSA, genomic tests, pathology reports. It's hard for any urologist to really balance the risk of all of those competing tests. So we know that AI has given us the ability to balance and really find a better clarity through all the number of tests that we order. And this is something that we hope to hear more about in the next few years. Another test, the ISO PSA, is a blood test that was developed here at the Cleveland Clinic with the help of Dr. Klein. It's now a commercial test that has been shown to be more specific for prostate cancer. We've continued to use this test in clinical practice. Dr. Abou-Osley, are you using the ISO-PSA routinely, or do you find that it's a helpful test?
I do. I use it to help risk stratify patients that come in to my clinic referred for concern for prostate cancer, usually elevated PSA. So if the PSA is over 4, then they're candidates to get the ISO PSA, and that'll help determine if I'm going to move on with potentially an MRI or a biopsy, depending on the results of the ISO PSA.
Right. And we together, our group published a recent study what was the update to kind of our experience with the ISO PSA. If you want to go to the next slide. And people who, we've been now run well over 2,000 of these ISO PSAs, but we looked at our results when we hit around 1,500, and we found that if you have a normal ISO PSA, chance of developing clinically significant cancer or having clinically significant cancer on a biopsy is 4.3%. So it's just a very good test that can be used as a rule out and may be able to avoid a prostate biopsy in some men. And just to kind of summarize some of the radiation oncology ongoing clinical trials, a lot of them are looking at men who've had treatment, whether it's they've had a radical prostatectomy or other types of radiation and have had a recurrence, or mainly their cancer has come back, and looking at various radiation treatments as combined with other types of hormonal therapies, whether it's abiraterone with prednisone, as well as apalutamide. And that's these NRG GU008. And then also looking at people who've had looking at kind of the genotype of the cancer in men who've had androgen deprivation and radiation therapy. Another clinical trial we're currently accruing patients for is called the FAST trial. It's comparing focal ablation to focal surgery. So this is one run by Dr. Jihad Kayuk and Dr. Oliveris, looking at HIFU, which is the ultrasound ablation and is a focal treatment, to instead of doing an ultrasound focal treatment, we remove that part of the prostate and seeing what are the outcomes. So we are currently having good, accrual of those trials, and it's something that if you're interested in focal therapy, it might be worthwhile asking if you may be a candidate for the FAST trial. So that was a good kind of overview of some of the ongoing clinical trials that we've had. We're going to open up the rest of the time for questions, and we can maybe go through some of those. We'll try to limit, and everyone I'm sure probably has, a very specific question about their situation, and we can do our best to answer it. We'll try to, focus a little bit more on kind of the research advances that, may be related to your unique situation. But I don't know, Betty, have you seen any of the questions that have been submitted so far?
Yeah, there is one kind of more general question in the chat box. So someone, William, had asked, like, what are the selection criteria for focal therapy? This might be one that applies to more people. I figure if you want to take that one on.
Yeah, Rob, do you want to go ahead and answer?
Yeah, I mean, candidates for focal therapy. So ideally, these are patients that have disease in one area of the prostate, and that is based on biopsy, and that corresponds to a lesion seen on the MRI. So if you have a lesion on the MRI that's suspicious and the biopsy confirms that you have clinically significant prostate cancer in that area, which typically is grade group 2 or Gleason 7, 3+4 prostate cancer, and the lesion is in an area that's amenable to ablation. So there are some parts of the prostate where it's a higher risk to ablate, such as near the sphincter or near too close to the urethra. And so in that case, may not be a candidate, but otherwise, if you fulfill those criteria, you may be a candidate for focal ablation. Anything I'm missing, Ziad?
Yeah, no, I think you hit the main points. The intermediate risk localized to one area. Another important point is that it's not a substitute for surveillance. So, we really shouldn't be treating your disease if it's just low risk or Gleason 6 prostate cancer, because really the best way to reduce the side effects of treatment is not treating it at all, unless it's the type of prostate cancer that your urologist recommends treating. But, it's not something that we need to just start ablating everybody with low risk prostate cancer.
Right.
And then there's also been questions. So is the ISO-PSA test useful for patients on active surveillance as a substitute for repeat biopsy? And is it available in the Toledo area?
That's actually a very good question. And we are currently studying that. We just did an initial retrospective test, which we kind of just looked back to see, if someone who had an ISO-PSA that was elevated, to see if that predicted if someone who was on active surveillance, eventually was diagnosed with clinically significant prostate cancer. And the early test was no, it did not. But that was in a very small subset of men. So really the best answer to that is we'll see. But we're currently trying to answer that question. And then the other is ISO-PSA available in the Toledo area? I do believe they partnered with other labs. And I believe, if I'm not mistaken, it might be Quest or one of those types of other, more nationally available labs. So it might be worth calling your local lab to see if they offer the ISO-PSA. I think Toledo is not too far from Cleveland, so some people can get a lab closer to the west side. Rob, you probably know, since you're near that area, if there's a lab closer to Toledo.
The ISO-PSAs have to be done in hospitals, as you know, Ziad. So because the specimen has to be frozen, if I'm not mistaken. So a lot of times, we send patients to either Avon Hospital or Fairview Hospital. So Avon Hospital would be the closest to Toledo, which is still a little bit of a drive, but it's off of the freeway there.
Great.
Perfect. Okay, so I'm just going to go back to some of the questions that were submitted before the session. So this one is a 70-year-old gentleman. He says he's in good physical shape. He's taking Xtandi or enzalutamide for metastatic prostate cancer, which is recently diagnosed. He's asking, is this good, or is there any other combination treatments beside lifestyle-destroying hormones such as Lupron?
Yeah, no, that's a good question, Rob. I don't know if you want to.
Yeah, I mean, I think that's in our practice we tend not to treat a lot of the metastatic prostate cancer patients. We work a lot closely with our medical oncology colleagues. A lot of times, the standard is to start an anti-androgen with either a Lupron or a similar drug to Lupron, which blocks the production of testosterone. So you both block the production of testosterone, then block it at the receptor. And then depending on the site of disease, extent of disease, consider adding additional therapies. For example, if most of your disease is in the bone, sometimes they'll consider one of the radiopharmaceuticals that are active for metastatic disease in the bones. And there are other potential trials depending on the location of your disease. But again, a lot of times we'll partner with our medical oncologist to get specifics on what you'd be a candidate for.
Yeah, I second what he's saying there. And actually, that's always worth getting a second opinion, with our medical oncologist colleagues. If you're on a treatment protocol or, that you're not really sure if you need or absolutely want to have, or see if there's another option. There's a ton of newer drugs. A lot of them now, unfortunately, we're finding that adding more drugs to the combination is actually, for some men, better from a cancer treatment standpoint. But a lot of these medications have side effects. Sometimes it may just be trying, a different combination of medication. So.
One of the second questions was, this is a gentleman, he's had a prostate biopsy showing 10 out of 13 cores positive for cancer. He's 75 and he had his prostate removed a couple months ago this year. It was discovered that not all the cancer was removed, and he was recommended to radiation for the remaining cancer. He's wondering if this is common practice or just unique to his scenario.
Well, I think unfortunately we do see that. So a few things you look at, when you do the prostatectomy is you look at whether the disease was outside the prostate when the prostate was removed. So is it a stage 3? In other words, did it invade into the fat around the prostate? Did it invade into the bladder neck fibers, the muscle fibers of the bladder neck, making it a stage 3? And what were the margins? So, was there cancer on the edge of what was excised? The other thing we look at is the pattern of disease, the grade of the disease. So, if it's high grade, more high grade disease, then you want to be more aggressive. So if you have some of those features and your PSA either was initially undetectable and then became detectable or was never undetectable, then you'd consider salvage radiation. Again, there are a few caveats to that. You may want to get a PET scan first just to make sure that there's no disease outside of the pelvis, that in which case maybe the salvage radiation wouldn't be of benefit. It's particularly for patients with high-grade disease or PSAs that never really became undetectable or higher. Ziad, do you agree?
Yep, yeah, that's certainly an advantage and disadvantage of having surgery. First is that you get radiation if the cancer has returned. Not everyone needs radiation if their margins were positive, like he was saying. A lot of it depends on your PSAs, the risk of the disease at the margin. This is something where genomic testing might be helpful to determine. Sometimes they can send the DNA from the cancer at the edge of the location where the margin was positive, and that can kind of determine how likely you're going to need radiation. So yeah, that I see a good question about how common is cribriform positive. I'm guessing you're saying cribriform cancer, and is treatment different than cribriform negative? It's a very, very good question, and this is something that is cribriform is a pattern that is associated with a Gleason score usually. So a lot of times it will be, intermediate risk or Gleason 3+4, 4+3, or 4+4 with cribriform. So it's an additional pattern that they see, and it's actually more common than we think, especially in the higher, risk prostate cancers. And that's something that is probably one of the most independently shown pattern to be associated with metastatic prostate cancer and life-threatening prostate cancer. In the low-risk prostate cancer, it's very uncommon. Like if it's in Gleason 6, it's rare to find cribriform, but in intermediate risk, it can be present in between 20 to 30% of cases, and it should be treated differently. It should be, instead of watched, it should be treated. I would, in most people, advise against active surveillance in people with cribriform positive prostate cancer. And I also would steer them away from focal therapies because cribriform is associated with likely having cancer elsewhere in the prostate, whether it was found or not. And that would make you at a higher risk of a recurrence if you have a less, aggressive treatment. So I would usually advise towards, treating that a little more aggressively. Rob, do you manage cribriform in a similar way?
Yeah, definitely. I mean, it's a suggestion that the disease is a little more aggressive, so you want to be a little more aggressive in your management. And as we're also looking at whether these types of patterns that we see on the pathology reports, such as cribriform, can predict response to radiation after surgery or other treatments. So that research is ongoing.
Yeah, it's also important to realize that not every genitourinary pathologist is trained or is reporting this on your biopsy. So if you're not sure, if there's no comment on it in your pathology report, it's actually worth getting a second opinion or having your slides sent to a larger center like ours. to get a second read on the pathology report to see if that may be present or not present.
Yeah. I see there's a question asking if we can comment on testosterone replacement therapy in early stage, so grade group 1 prostate cancer.
Yeah, I mean, there's some evidence that it may be safe in patients with low risk disease or patients that were fully treated that have no evidence of recurrence. Obviously, you want to be cautious in doing that because we know that prostate cancer feeds off of testosterone. And so if you are on active surveillance and you want to, be on testosterone replacement therapy, we do want to make sure that you truly have grade 1 prostate cancer, low risk prostate cancer, that there isn't a more aggressive pattern that maybe was missed on the initial biopsy. And so in that case, we want to make sure that we potentially get an MRI and maybe a restaging biopsy to confirm that it truly is low risk. In that case, studies suggest it may be safe to replace it to a normal mid-range level. Ziad, do you feel the same?
Yep, absolutely. I usually will be hesitant to start testosterone replacement therapy at the beginning of kind of while we're still trying to figure out, is this only low risk cancer? And if things have remained steady for a while, and you've had your second confirmatory biopsy, then I'll have the discussion and explain the theoretical risks. And if your PSA jumps or if something worrisome changes, then stopping it very quickly.
There's one patient's wondering, so he's currently on active surveillance doing PSA every 6 months. Would 3 months interval be overkill?
I think most of the protocols, I mean, once you've been risk stratified in terms of you've had your confirmatory biopsy and you have now 2 biopsies which confirm grade group 1 low risk, low volume prostate cancer. Every 6 months is probably added more than adequate. Every 3 months, unless there's a change in the PSA, the kinetics of the PSA has changed, and you want to keep closer tabs on that. But if things are relatively stable, I don't think there's much benefit to doing it every 3 months compared to every 6 months in those situations.
Yeah, I agree. I see a question can I comment on the percentage of transperineal versus the percentage of transrectal prostate biopsies in 2024? Is there any difference in the amount of patient pain or discomfort between the 2 biopsy techniques? Very, very good question. And this is something that in the last 5 years, the percentage has gone, a shift towards in favor of transperineal versus transrectal. So as more urologists are trained in doing this biopsy approach, which they may not have been doing before, a lot more people at our institution are doing the transperineal approach to reduce the risk of an infection. There is some evidence to support that there might be some increased pain, although that is a very minor difference. A lot of it has to do with the training of what type of local anesthesia that you're getting and receiving. So the important thing to be able to do is to block the discomfort with lidocaine at the skin and the muscle level. And that's something that requires a little bit of training and experience. So it's something that more experienced urologists tend to have very similar pain scores with their patients who undergo a transperineal compared to a transrectal biopsy. We also offer newer anesthesia techniques. We have at the Cleveland Clinic Pronox, which is a nitrous oxide mild sedation. It's what people would usually get at the dentist's office. That has shown to reduce our discomfort with the transperineal approach. But much of it comes down to the technique of the local lidocaine block.
Yeah, I agree completely. I think it does take some practice and training to get to the point where you're doing a good block. But once you learn how to do a block, I don't think there's any significant difference in discomfort between the 2 approaches. And I converted to transperineal over 2 years ago, and most of my patients say that it's no different in terms of discomfort.
Yep, I agree. I've done many hundred in the last year of transperineal. I did one transrectal biopsy from a patient who kind of refused to undergo the transperineal approach, and they're the only patient who ever had an infection in the entire year. So that's something that has really dramatically changed the risk of getting a severe infection. And I agree with what Dr. Abouasli says, that I don't see a difference in the discomfort.
There's a good question in the chat. So Addison says, his biopsy came back as Gleason score 8. However, after if I read this correctly, after surgery, it came back as Gleason 7. So which one is more accurate?
Yeah, that's a very good question. And in short, the surgery specimen is the more accurate reporting of your Gleason score. When we're doing a biopsy, we're just sampling small parts of the prostate tumor. We don't necessarily have a full, assessment of what type of pattern is the dominant pattern. During the biopsy, maybe the sample was done at the higher risk portion of the tumor. But when we get the final pathology report, it looks like you've been what we call downgraded, which is actually a good thing in the likelihood that the cancer will ever return. Most of the time, that just means that they now got a bigger look of the entire tumor, and they found that the higher risk pattern was actually the minority or the smaller part of the tumor overall.
This is one of the questions we got before the session, but this patient says, his prostate cancer was diagnosed early with a Gleason score of 6. It's considered isolated and non-aggressive. His doctor recommends active surveillance for now. Would you guys agree?
Yes. Sorry. So you said it was a Gleason 6. Do we know how many cores or what the PSA was or any other? Yeah. I mean, I think based on that information, I would say definitely would consider active surveillance. Again, there's a little more information we would usually gather just to be sure. Have you had an MRI? Is there a suspicious lesion that maybe wasn't targeted on the biopsy? Is your PSA out of proportion to what the biopsy shows, or any other concerning factors? But otherwise, in the absence of that, and if the volume of disease is relatively low, typically we say less than a third of the core is involved. But again, there's some flexibility there depending on your desire to be on active surveillance or your other medical issues and life expectancy. But based on the information we have, I think definitely would consider it, but making sure that there are no other features which would make you not a candidate.
Yeah, I second that. It's sort of a little bit of the art of active surveillance. It kind of requires taking a look at what the story is being told by all of these different markers. If all of the markers, the MRI, the biopsy, the PSA, are pointing towards the low risk, then usually that's a good sign. Sometimes, though, there can be kind of a little bit of a mismatch, and that's where we kind of have to maybe do additional tests, do another biopsy earlier to determine, okay, is there anything more aggressive that might need treatment?
So this is combining kind of two questions together. So one of the patients earlier had asked, what should they ask their doctor if they want to be considered for these clinical trials? And then also this a follow-up question was, if they know their own clinical history, is there an email that they can contact to see if they're a candidate for any studies?
I think that I think that if you're not, so first, not every center is going to have the clinical trial open. The ones that we talked about were the ones that are open at the Cleveland Clinic, and there may be a few others that we didn't get to. But yeah, you'd want to check what trial you may be a candidate for. Is it available at your institution? And then meet with one of the providers to see if when they go through the inclusion and exclusion criteria, if you meet the criteria to be considered for that clinical trial. So we don't do a lot of email because also we worry about patient information. It's not very secure to exchange patient information by standard email.
Um, and then I think I'm just trying to see if we covered a lot of these questions, trying to see if there's anything else. Dr. Schwen had also answered most of these. One of the patients earlier had asked, what are our thoughts on MRI reliability?
Well, I mean, Ziad can probably chime in as well, but I guess, so there is variability in, one, how it is performed. So, just because a center is offering a prostate MRI, it doesn't mean that they have the expertise necessarily to do it in a way that provides the information that would be required to really make an informed read on the prostate. So there is some variability in how it is performed, and then there's also variability in how it is read. So radiologists, it does also take some experience to learn how to read these MRIs. And we're very fortunate at the Cleveland Clinic that our radiologists have read thousands of prostate MRIs, so they're quite good. And a lot of times when I get an outside MRI, I'll have them take a look, assess the quality of the MRI, and see, if their interpretation is the same as what was interpreted by the outside radiologist.
Yeah, I totally agree with that. A lot of it has to do with the machine. Is it a 3 Tesla MRI, which is the better quality MRI? But it's really also coming down to the radiologist and their experience, in like Dr. Abu said, how many they've seen. It's always good if your MRI was done or read by a radiologist that does all types of radiology, isn't subspecialized in genitourinary radiology. It's may be worthwhile sending your scans for a second read. We commonly will see those reads change. We also have done some research looking at something called PyQual, which is a measure of the quality of the scan image itself. How clear is the picture? Is it useful? And a lot of evidence supports that a better, clearer picture, not surprisingly, has been associated with a better detection rate on the biopsy. But at the same time, it did show our results that the MRI is a very durable test, meaning that it's pretty good at finding the nasty tumors and would only miss about maybe 10% of prostate cancers, which is actually surprisingly pretty good for a test to have a 90% likelihood of finding your cancer, because we don't usually just rely on one test anyway. So that's why it's kind of a pretty good test, no matter where you get it.
Okay. Megan, do you know if we have any more time for questions, or are we
Yeah, I think we're wrapping up here. It's something that if there's people here that haven't been seen at the Cleveland Clinic, we actually have a service that we may include in kind of an email that goes out. That's a second opinion service that the Cleveland Clinic offers. It's called The Clinic by the Cleveland Clinic. And even if you've not been seen here before, you can get a pretty quick second opinion on your cancer case, whether it's with a urologist, if it's a localized disease, or a medical oncologist, a radiation oncologist. So that's something that is a good opportunity to get kind of your specific question answered about your case in a form of a second opinion.
okay?
Well, thanks everybody.
Thank you, everybody.